Good morning, everyone. My name is Sinisa Zerajic. I'm a family physician in Saskatoon, and our project looked at improving identification of depression and anxiety in patients with diabetes. So when it comes to patients with diabetes, we know that psychiatric comorbidities can have a negative impact on blood sugar control, diabetes-related complications, as well as quality of life. And unfortunately, it is apparent that depression and anxiety remain underdiagnosed in this patient population. Therefore, it's not surprising that Canadian diabetes guidelines recommend regular screening for psychiatric conditions in patients with diabetes. So as it turns out, at our clinic, the Westlands Primary Health Center, we could be doing a better job when it comes to screening for depression, anxiety, and diabetic patients. Screening rates for eligible patients are around 60%. However, it is not clear how the screening is done, and rate of utilization of validated questionnaires is almost zero. So it is more likely that during a busy visit when many other issues need to be discussed, diagnosis will be missed or delayed, as there is often very limited time to appropriately screen for these conditions. So our aim statement was to increase screening rates for depression and anxiety in patients with diabetes at our clinic to more than 90% by August of 2020. And we also aim to standardize this process by using validated questionnaires. So we came up with our first PDSA cycle where we used clinical decision supports available in the EMR to automate the process of identification of patients who require screening. So we used questionnaires PHQ-9 for depression and GAD-7 for anxiety to screen patients, and these would be given to them to complete prior to the CBM visit. And we established a workflow where, depending on the results, another visit could be scheduled to address mental health concerns, or if red flags were present, those would be addressed right away. And as a balancing measure, we looked at any perceived negative impact on the workflow. So unfortunately, we didn't get very far. The start of our PDSA cycle coincided with the beginning of the pandemic, and within a week of when we began, everything shut down and things basically came to a halt. And unfortunately, we haven't been able to restart the project. So in the future, if the project is restarted, we could look at developing a process that will consider the new reality of virtual care and how to incorporate screening into virtual visits. We could also look at whether increased screening rates resulted in a significant number of patients being identified with depression and anxiety who were previously undiagnosed. And ultimately, we can look at whether this actually resulted in improvement in diabetes-related outcomes. So some of the things I've learned through this process is that it's helpful to go into a QI project with an open mind and to be open to change, but also with the mindset that there will be obstacles along the way. And being open to change and working through these obstacles is the only way to advance the project forward and ultimately grow as an individual and improve your skills.